Good afternoon, everyone. My name is Fritz Kunlens. I'm the Senior Director for Alumni Affairs at Berkeley for the college and the conservatory. We are delighted to have all of you here today. We've got a very robust group, a very large group tuning in. So we are certainly delighted to have our panelists who have stepped away, so to speak, from the front lines to talk to us a little bit about their experience as music therapists in the field. And we have our amazing moderator and curator of this conversation, Joy Allen, the chair of the music therapy department at Berkeley, to join us. So before we get started, I just want to give a little bit of information about today's webinar. It is a 45-minute conversation with a 15-minute Q&A, and we are going to do a hard stop at 2 o'clock. Today's webinar will be recorded and will be available beginning Tuesday, April 28th at noon. So if you are interested in tuning in for that, you will be able to see that recording via our social media channels. So check out Berkeley Alumni next Tuesday at noon, and it will be there. So without further ado, I would love to introduce our panel. So Joy Allen joined Berkeley as the chair of the music therapy department in August 2016. She is an accomplished clinician, supervisor, researcher, teacher, and administrator with extensive experience in psychological health, pain management, and the family approach. She is particularly passionate about working with individuals and families facing chronic illnesses, including cancer. Her current research interests include quantitative analysis of the effects of music therapy on the psychological health of mental patients, guided imagery and music with medical patients, and medical music therapy theory, development, and efficacy. She comes to Berkeley from Loyola University in New Orleans, where she served as coordinator of music therapy and associate professor. And if any of you have had the pleasure of meeting Joy, having coffee with Joy, she really lives up to her name. So Joy, without further ado, I'm actually going to turn things over to you to introduce our panel and to continue the conversation. So welcome.
Thank you. And I'm so happy to be here, and thank all of you for being here, and thank our panelists for being here. And they are extremely busy right now trying to meet needs of their respective facilities. So I do really appreciate and want to acknowledge their time and commitment to sharing information with us in our community. Another one of our alum, Channing Shipping, who works at Dana-Farber, recently posted on Facebook about essential and what is essential in a hospital setting and what is not. And is music essential? Is music therapy essential? And at the end of the day, hospitals would continue to function without it, treating diseases and conditions. However, music therapy is about providing holistic care to the person. And music therapists work together with their clients and their treatment teams to really make sure that the person and the family that is undergoing the fight remains intact. And when they are broken, to help them pick up the pieces and arrange them into something beautiful. And I think those words are very true to what we're doing and what we continue to do in our work in medical settings. And so I'm really honored that today we're going to hear from 4 expert change makers in the field from across the country who are first going to share with you what their mission is at their current hospitals, and then really talk about how that's shifted in response to COVID. And then talk about where do we go from here, and what can we continue to do as we're trying to address the trauma, the healing, but as well as to make sure that not only our patients get what they need, but how we can work with healthcare professionals as part of a team to make sure that we're in this fight together and we support and build each other up as part of that fight. So we're going to start with just each person introducing themselves and talking about their role, and then we'll go from there. And we decided to go East Coast to West Coast, South to North. So we're going to start with Caitlin Hyatt, who's here in Boston. So Caitlin.
Thank you, Joy. That was beautiful. So my name is Caitlin Hyatt. I am the clinical operations manager for a company called MedRhythms. We are contracted through Spalding Rehab Facility as well as other facilities and really serve the continuum of care, both inpatient, outpatient, and then in-home setting. So our clinicians basically have a role in all of those from an inpatient and all the way through. And our real scope of practice, MedRhythms specializes in neurologic music therapy. So we are serving different levels of care within the Spalding network, including their inpatient rehab and their acute long-term care facility, and even to their outpatient locations. So our therapists are working at different levels with different populations, but at my facility where I currently work, I work mostly with traumatic brain injury, stroke, and the spinal cord unit in their inpatient rehab.
And Rich.
Hi, everyone. Thanks so much for having me. It's so great to see so many beautiful faces over here. My name is Rich Avanti Motes. My full name is different on AMTA. It's Rita Antonia, just so that you know if you see my name. And I'm the program manager for Advent Health Central Florida. So we are a large faith-based hospital system across the country. And in Central Florida, we cover about 10 different hospitals. And so what's really great about having a faith-based hospital is that our focus on holistic care is really top notch. It's in our mission. And so that's the reason why I think music therapy is essential in our environment. And so our music therapy team, we have a pretty eclectic team of 11 of us right now, and we cover everything from adult inpatient to a full children's hospital. We also own a hospice that we provide music therapy for, outpatient pediatric rehabilitation, adult neurorehabilitation, inpatient, and basically any population we cover over here in the Orlando metro area. And I'll be looking forward to speaking a little bit more about that later. Thanks, Joy.
And Seneca, who's up in Ohio.
Great. Hello, everyone. It's a pleasure to see everybody, and no, I'm not in a music store. This is actually my home office. But I want to say thank you for having me here for this panel discussion. I am at University Hospitals of Cleveland. I work as the Expressive Therapy Program Manager, and we implement both music therapy programming, but we also have art therapy. We're delving into dance and movement therapy, and we have several fairly robust internships. Currently, before the pandemic, we primarily focused on providing non-pharmacological treatment for stress, pain, and anxiety across several adult inpatient units. As I mentioned, we're located throughout 10 of our medical centers. But in addition, we're part of a larger integrative network, which includes practices such as acupuncture, massage, and chiropractic services. We'll talk a little bit more about the shift we made to keep our program 100% virtual. I think as we all will, but that's sort of my intro prior to all of this.
Thank you, Seneca. And Jenna, who's over in LA.
Hi, everybody. Thank you for having me, Joy, and everybody. So I'm at UCLA Mattel Children's Hospital / UCLA Health. We have a new program that we are in the process of building that started in 2016. So we're hardly 4 years old. We are in 2 hospital locations at this time, serving all of our inpatient pediatric units, including the neonatal ICUs in both locations, and also our maternity units, labor and delivery, antepartum, postpartum units. We also are recently expanding to our adult population, so serving adult palliative and adult ICU end of life. And our overarching mission is to begin offering music therapy services to as many programs and units within the whole of UCLA Health as possible, which is a much larger organization. We're a small, tiny, intimate children's hospital within a much larger health organization, and we have very gradually started to make little waves, and we hope to expand and get music therapy services where they're really needed. Technically, my role is the manager of expressive arts therapies, although we don't have funding yet for the other expressive arts therapies, and that is another goal of ours, is to get art therapy, dance therapy, drama therapy on board. Yeah, and that's pretty much all.
Thank you. And you can see we're going from NICU to end of life in between. And I know some of you are still on site offering services, and others it's completely virtual telehealth, and then there's a combination of both. And I really would love to capture to see how we've shifted the continuity of care and the programming while ensuring the health and safety of patients, whether it's from, shifting into virtual versus a mix of virtual, non-virtual, or telehealth, to new initiatives that might focus more on staff support and staff trauma and burnout, to shifts in how you're able to deliver services, whether there's new equipment. And I know this is a loaded question, but if we could just see, start capturing some of those shifts that are happening right now at your respective places. And I will ask that all of you can, all of our presenters can unmute and connect on that as a whole.
Sure, Joy, I can jump in there too. And just as you're speaking about that, the first thing that came to mind for me was really considering the role that we as music therapists play within our medical centers. Addressing psychosocial vulnerabilities within these populations that have these barrier issues that are being created by this pandemic. But additionally, making the shift to virtual was also a big choice for our team. And I'll let I know I've worked closely with Rich, and we'll talk. Let everyone else talk about what they've done. Mm-hmm. But at the same time, there's also a responsibility to preserve PPE by making that virtual shift. So that's something
I just want to make sure everyone understands. PPE is personal protective equipment. And if you've been paying attention to the news, there's a shortage. And that is one of the challenges in terms of what services can and cannot be offered. And there's been a lot of elective procedures, not that they weren't necessary, but they didn't have to be done, that have been shifted, which impacts work that's being done as well because of that personal protective equipment. So just so our audience knows what PPE is. Absolutely.
And again, I'll just wrap up that thought by saying, so first off, I think that there was a responsibility for us as therapists to just act responsibly, and if there was a way to help with that, shifting virtually was a way to help with that. The other last thing I'll just share is that so far for us across our medical centers, this has really been an organic process where we've had sort of the pendulum swing to the virtual end pretty far. So to the point where right now we're currently offering 100% virtual services to both patients, staff, and community. But we're actually implementing a second phase where we switch back and we have a soft re-entry along with our state of Ohio, which starts in May. And again, those have some policies behind them too. I'm also on a COVID-19 task force for the American Music Therapy Association, and we've released some of these guidelines on that page as well. But I'll pass on to others to share more about their facilities and what's happening.
So I want to give a shout out to Seneca because he was such a great resource for me what seems like forever ago now, just like 5-6 weeks ago. And as you can probably imagine, we were all in the units and we didn't get a lot of guidance in terms of what we were going to do, which I found in my conversations with some of my colleagues, they relate to that as well. So we're actually doing a hybrid. Technically, our team is in a staggered scheduling right now of basically Team A and Team B. And 2 days our team works from home for shorter days, and we're here for longer days providing telehealth for our inpatients. And then we're still providing staff support. We have a thing called Motivational Moment. So we still go into non-critical units. And these are units that we have been providing support to previously and providing music to staff in a socially safe, socially distancing way. But on the other side, for example, Cancer Institute, our unit really appreciated the fact that we're still providing services, especially for these cancer patients that they're already isolated anyway. And so the way that we've been able to manage that is to provide in a cancer infusion center, they're chairs, they're not beds. And so more like pod-wide music engagement rather than individualized music beside the chair. But for our telehealth sessions, we're still able to provide what you would normally think as normal music therapy interventions. Obviously, there are barriers to musicking together, and so we'd have to limit that a lot. But basically, our pandemic response is threefold. Number one, how do we continue providing essential music therapy services to our current caseload? And so transitioning all of that to telehealth. But also, there's this big elephant in the room, which are COVID units. And our hospital, Orlando, in our county specifically, is the hardest hit in our area. So this week, we have a virtual visitation team, which is a different team led by our clinical experience department, where they have Chromebooks and they have staffing that can provide a device to our COVID patients. And this week they're going to start offering that to families, especially for end of life situations. We haven't had a request go through yet. I got my first request yesterday and didn't go through. But the second arm of our response is staff support, which is really, really important. And instead of always being at the units, our presence is not as felt. So we've actually created online video content that is disseminated through our company's emails for emotional and mental health support. And then thirdly, how do we transition all of our groups, which had a lot of outpatient groups that needed to be transitioned virtually, and all of those are going successfully.
So I'm going to jump to Jenna, because you had mentioned video content, and I want to dive in a few minutes, and Caitlin will get to you as well, in terms of what a telehealth session looks like compared to a regular, because I think that would be good for people to understand, some of those challenges from a case example. But Jenna, your team in particular, I know has done, and of note, interns, you've been phenomenal about involving interns, some of who are our music therapy interns from Berkeley, in terms of the video content, and how you decided, like, what video content do we need to get out immediately so that, we can meet the emotional and social needs because of the isolation being so real. And if you could talk a little bit of the process, if it was just, hey, let's just go, or if it was, okay, what's the immediate need? How do we do this?
Yeah, this is such a great discussion. I mean, it's kind of helpful to reflect back, because honestly, everything happened so fast, and we had to really use our flexibility and creativity that we have as music therapists to just jump to it and quickly do assessments and prioritize. In our situation at UCLA, we weren't necessarily getting directives from leadership about music therapy's parameters, other than, don't waste PPE and social distance as much as possible. But we had no directions to do telehealth or anything like that. So it was more this urgent dilemma to decide what was the most responsible decisions to be making for the program, and how can we keep normalcy for our patients and families, and also for our interns, because from a trauma-informed lens, normalcy is crucial. And we kind of did a combination of a lot of different things. So Joy was mentioning some video content. So our music therapy team came up with the idea that we got all of Child Life on board with, to make a YouTube channel that patients who are, not necessarily considered high priority because maybe they're not in extreme agitation, or maybe it's not an end of life case, and maybe they have some form of psychosocial support already, but they're still extremely socially isolated when this all first happened, before we were in a groove of doing Zoom sessions. So we wanted to get therapeutic video content ready for them. And we just recorded guided relaxations, sing-alongs. We just started cranking out as many ideas as we could of things that were entertaining and also therapeutic that could be delivered to patients, kind of to say, we haven't forgotten about you. Here's familiar faces and the familiar environment, the playroom. We're not going to be coming into your room 3 times a day like we normally would and using PPE, but we're thinking of you, and this will hold you over for a minute. And then that way we were able to start setting up Zoom sessions with the patients that we really did need to be seeing on a regular basis over Zoom, and get the interns set up through telehealth, which was a process. I think at first it was a little bit daunting and definitely frustrating to try and get into a groove of getting responses from people, scheduling. There was a lot of no-shows. I know our current music therapy interns were getting really disappointed and feeling a little insecure. And it just took a lot of persistence and over communication. And luckily, I was still on site and able to connect the dots, help get people set up on an iPad on Zoom to make that initial connection happen. But we kind of did that combination of the YouTube channel where patients got a little QR code that they could scan and it would take them right to the YouTube channel to see our familiar faces and do some therapeutic exercises. And we switched to Zoom sessions for the majority of our sessions other than end of life and extreme agitation cases. And then we had a dramatic increase in our staff support offerings. So basically every day we have a staff support offering for our emergency department staff, for our residents twice a week. We do an online support group that they have going called the COVID Cafe. And their logo is the Starbucks logo with a mask over. And music therapy always guides relaxations and helpful prompts to facilitate more discussion about the unknowns and uncertainties and fears that a lot of them are dealing with. We have offered regular support to all of our ICU staff and all of our pediatric inpatient staff through an increase in environmental music as well, where we can socially distance. So it just kind of feels like, it almost feels like there's more music now in the hallways than there was before. And the overall reaction has been, thank God you guys are still here, which has been really eye-opening for our team. But yeah, still, of course, trying to be mindful to limit our use of PPE and connect digitally whenever we can, and just be patient with patients and families as they get set up on Zoom and approach things through the lens of empathy and understanding, okay, I'm probably not the only Zoom call they have today, and they're under a lot of stress and they're not with their families. We have really intense visitor policies right now that pull people away from their families. So we're trying to be as respectful and empathetic as possible when we introduce Zoom sessions, in communicating that it's just an optional support and not meant to be an added burden.
And Caitlin, can you add to that with some of Jenna is pediatrics to end of life in an inpatient hospital setting, and Caitlin, yours is different. It's a rehab setting, but rehab can't stop.
Yeah, so we, when all of this hit, I think it was, to give you a little perspective, MedRhythms has actually, we were in the process of developing a telehealth platform anyways, because we were thinking about, we get a lot of inquiries from people across the world really that are interested in this level of care. And so when this happened, we had already had a talk about it and decided that, out of crisis comes an opportunity. And so we were going to use this as a way to, not only meet the needs of those that we're treating on an in-home level and completely switch over and stop going to people's homes and switch to a telehealth platform. But at Spalding, we are still, all of our staff are still going to the hospital their normal work days. And, I think the idea of that word essential is more of that we align ourselves with the other therapy disciplines, so that if PT, OT, and speech are going to work, so is music therapy. And so that has been pretty consistent. We obviously have transitioned with the hospital regulations that are in place. And so, if the PT has to treat in the room, we're treating in the room, we're wearing the protective gear that we need, and keeping in mind some of the considerations of decreasing the amount of things that we're taking from room to room. So we might be scaling down the typical equipment that we would go in with. And of course, we're not doing any groups at Spalding, but we are still treating patients our typical 5 hours a day. And one of our Spalding locations, Spalding Cambridge, which has actually converted in, they have 2 COVID units. And so they transitioned that hospital. So our therapist who was designated at that hospital, all of his caseload, which he focuses more with severe traumatic brain injury or disorders of consciousness, transitioned to their inpatient rehab facility. So we ended up having that therapist also to continue the care that they were receiving, transition to Spalding Charlestown. So we have actually more, similar to Jenna, we have more music therapy happening at Spalding Charlestown, and they have continued, and he's been able to continue with those patients. So the switch to telehealth was really big for not only, I think us as a company, because this is something that we want to continue beyond as a way to provide access to this level of care that people don't have just because of the location that they're in, but also an opportunity to really keep the continuing of care in a rehab setting. So it's not as intensive, I would say, as like your typical medical centers, but we are still continuing that. So.
Caitlin, one thing you mentioned that I wanted to just add to is you mentioned the idea of this being an opportunity. And I think that's something that's really helped our team and something that's helped myself just kind of compartmentalize all this and process it, is that there may not be a new normal that we're going towards, but this is also an opportunity for revolution, I think, for our field and for the way we do things. And I was talking to another mentor who brought up the concept is that once you switch to these different methods and you try these different modalities, ways of offering your services, you may find that you found increased capacity, and you may find new ways to practice and things that actually push us forward as well. So I just really resonated with what you said.
I agree with Seneca about the innovation piece. We've definitely extended. Another therapist told me, man, like we are really pushing the boundaries of what we can do here, which is absolutely true. At the same time, too, what Jenna said about more environmental music, we're doing that as well. And when we had planned this, that includes music at shift change at one of the main entrances for our staff. And I was about to meet with my team, and it dawned on me, it harks back to the beginnings of our profession, when, and that was really an emotional moment for me, if I'm being completely honest. Our profession started after the war when there was so much trauma, and they brought in musicians into hospitals. And in the beginning, when we started to do this live environmental music, quite honestly, I'm one of them too. I was like, this is a nice thing we're doing for the staff. Let's just go ahead and do it. But that first 2 weeks, we were getting some amazing feedback from the staff. And the point is not for them to congregate and watch a performance, but really is to interrupt and disrupt all the anxious thoughts that they're bringing into work. And also that people could be bringing back to their homes, to their families with beauty, getting them ready, even for a few seconds. They focus on that thing and they're ready to go back into tackle the day. And so I just resonated with that, Jenna. There's more music in the hallways, and that's nice. And it's allowing ourselves to feel like this is important too.
Well, and I think it's the targeting of that music too, Rich and Jenna and Seneca, and Caitlin too, because when we talked about, and Rich, I'm glad that you brought that up in terms of the beginnings of the profession in the United States, really came back from World War II, and nursing staff, even on the field and addressing pain and not having medication, but they knew that they could use music to affect physiological responses, which then helps address those emotional responses. And then in that target, automatically the song that came into my head was Take 5 by Dave Brubeck, right? You take 5 minutes to stop, let me just transition. It's a transition. And you didn't fix anything, but you provided an opportunity to transition. Correct. And that 5 minutes might be the most important thing. And often, even times in medical settings, it's about using the music for them to share their story, and that this is where I am, this is my story, and that's okay. But I wanted to go back to, in terms of there being more music than there ever was, and it's shocking to me that oftentimes it's almost as if we take music for granted, because it's something that we're, from conception on, is there, our heart rate. And we just notice it. If you watch a movie, you might not pick up on a particular piece of music that's in that soundtrack, but you might be experiencing it, right, through those emotions. And what happens when you take the music away? And here we've noticed we need more. But I wanted to get back to the part of talk us through what, I think about a child, and when we're working with a child or even an adult and we're in the room with them and how we engage them with music, it's much easier because we're right there. We can hand them an instrument. We can move their hands. If we're working with motor skills, we can do hand over hand. And those things are hard telehealth wise. And so you may need someone to help in that engagement, or we all know what it's like to be on Zoom all day by now, or it's, do they have access to the Chromebooks or the internet so they can get this? But can you walk our audience through what a telehealth session looks like and what you've had to do in terms of engaging someone in it, with a case example even, and how that has shifted your ability to engage musically?
Yeah, I can speak to that because I think this was a real question for our entire team of what is this going to look like and how are we going to implement it? And I think you come into those questions of ethically too, being able to deliver a quality service so that you are truly able to meet the individual's needs. And so I think when some of the things that helped us through this was really identifying, not limiting, because I think a lot of people have asked us, well, who's an appropriate candidate for telehealth? And I think at this point, the field is progressing in a way that we don't actually quite know who is and who's not appropriate. That's something that you have to decide using your best clinical and ethical judgment as you are with them. And I've, mostly have been encouraging people to just try it and really be able to assess the resources that they have available, the resources that you have available, the regulations that, despite the HIPAA regulations being lifted, being mindful of when they come back into play and the platforms you're using. And I also think just thinking about the overall setup, if you're delivering more of we talked about more music in the same regard, a lot of these people are looking for real in-home resources that they can use. So, is it that you're doing more of a consult, checking in with them, talking with them about the resources you've built, or is it more of a real in-time live session that you're giving them, in which it gets into more of a creative process of how are you using music to drive the change, right? So that piece of it of really how are you using the audio platform, and adjusting to things like audio delay, which I think if you've all followed celebrities on Instagram, they're figuring it out. So I think we can figure it out too, right? This audio delay and still being able to make music together. So I think it's more of just finding really creative solutions. But my advice to those who are starting this is really just identify the minimum necessary that you need to actually reach the people that you're looking to reach. Minimum necessary. And once you get into that process, then you start building from there. What do I need, or what can I develop for this? What would enhance this process? And I think that's when you start to figure out the best quality of care, and it really transforms into something that is really amazing and useful.
Seneca, Jenna, or Rich, do any of you have an example that you can share from an inpatient medical setting perspective? Or Seneca, you're completely virtual.
Sure. And I actually just shared in the chat bar the YouTube video that we created through AMTA for implementing virtual music therapy. Mm-hmm. But really, I think very similarly to what everyone else is saying, we think about it, all of this in a tiered approach. But what it would actually look like. So I'll share a case study. And I saw a question in the chat box too about how has this affected our therapeutic goals. I think what we're seeing across our medical center is a great deal of anxiety. And that psychosocial issue is something that we've been working to address with our telesessions. So what a session would look like throughout our medical centers, we're a referable service. So physicians or nurses would put in a referral for music therapy. We would receive that referral through our EMR, and then we would follow up with that patient. Ways we would do that is we would look through their chart for either a contact number, or we would call their actual room number. So we have a chart of all of those as well, and make that contact. Upon that, we actually have, and in that YouTube link, there's actually an example of a procedural flow chart that we developed to help aid that process, and also to keep track of who you've seen and who you've reached out to, because that can also get very confusing sitting behind a screen all day. So after that, for example, so a patient I received a referral for, it was anxiety, and she was having a difficult time coping. We'll say her name is Mrs. A. So Mrs. A was a hospitalized inpatient at one of our medical centers, and I gave her room number a call. The first thing I did was assess the patient for one, just her emotions, but also and to check that our service was applicable for her in the moment. She was agreeable to music therapy. I then did a technology assessment where I asked, do you happen to have a laptop? Do you have a tablet? Do you have a phone? This person, so I went through that list quite specifically, from the best option to what we can make work. This individual had none of those things, so we actually had to have a bedside phone session. With that said, however, even though the audio quality was not the best, through the phone, we conducted a relaxation session with preferred music, and I walked her through a progressive muscle relaxation. And pre-session anxiety was an 8 out of 10, and post was a 6 out of 10. So over that session, we saw a clinically significant reduction in anxiety in this patient. So post-session, I scheduled a follow-up. Another thing that's to consider about this too, we have, again, I'm bringing it back to capacity. One thing we added to our process was then asking for contact information. Would you like me to also share some resources and education with an email address? She was agreeable. She gave that email address, and I was able to share some community resources for her to utilize too, as well as having that contact professionally. And then, after that, it was the standard charting within our EMR system, and then scheduling that follow-up.
Thank you.
So ours is very similar to Seneca's. We actually developed an intake form to assess all of the connectivity things that are available to the patients, and then we also do consent. But just like how you would imagine a medical music therapy would look like, it's just over a computer. One of the earliest stories we had was actually phone. And it was just a relaxation exercise on the phone. And our hospital has these big open windows. And so our therapist said that the patient basically positioned his phone right there and looked out the window and took deep breaths. So that worked really well for him. But in the NICU, actually, I think one of our therapists is here, Kelly Patton. She does a lot of work in the NICU. And so instead of being at bedside and holding the baby and providing infant-directed singing and the touch progression, we are now focusing on family-centered care. How can we empower the parents? And so she's doing a lot of parent training and guiding the parents to do the intervention themselves with their babies. And so it looks very different depending on the need. We also have a Parkinson's group, and typically we would do a motor exercise with our Parkinson's patients and improvise. We can't do that right now, so we're doing a lot of neurologic music therapy exercises to warm up, and then we do a lot of vocal exercises, and then we also do some singing, but then we actually have to do some group management. So everyone has to mute their computers, because then it would be crazy. So all of these things we just kind of figured out as we went along. One of the things that has been important for our team is to really acknowledge and validate that this is not easy. You don't just get a computer and get started and everything's going to go smoothly. Most days it's just, like that session was horrible because the connection was absolutely nuts, or some things just don't work, and you give yourself grace, you take a deep breath, and you move on to the next session.
Yeah, I just wanted to chime in I see a lot of questions about therapeutic relationship, and I think it's really profound to be considering that, because technology is not necessarily the most natural component of a therapeutic relationship, but it is becoming a reality that will not go away. So a little takeaway that I have from a one-on-one supervision with one of our music therapy interns, who is at Berkeley, student as well, was she was processing a session that she had where she was super prepared, had a bunch of worksheets and songs and interventions in her telehealth cart that she has set up every morning with like a full plan for every patient that she's going to see. And she was really ready to dive in and do those interventions. And she said that the patient said something that just kind of stopped her in her tracks and got her thinking to approach things differently. So she gave a whole spiel of, we could do this, we could do this, we can this, and here's a worksheet. I'm sharing it on the screen with you. And then after her whole spiel, the patient just said, "Do you see my necklace? Do you like it?" And she had to slow down, take a breath, and said, "Oh my gosh, it's no different. I mean, just like when we go into a hospital room and we're with people in person, slow your roll, get to know people, what's in their room, what's going on with them." And that actually is a really important component to maintaining that confidentiality piece as well. You don't know if a doctor is coming in the room, if, you know, who knows what distractions come. Really pausing, taking that time to set up the room, even though you're connecting through a screen, is really important. And also, you know, not assuming that you're on the same page at all. Take time to find out where they are. Both parents, you know, the whole family, whoever is there.
So I'm struck by the level of, even though you have stated in terms of no one gave us a handbook, no one told me, no one from above came down and said, this is how you do it, right? And this is the technology you need. You guys are literally unfolding this in real time, like every help. No one gave us a handbook on a pandemic in general for society, right? But you're managing. And this will be my last question, and then we'll open it up. But I'm struck by, you know, no handbook, we have to go in time. And I have heard from people mention we've had to switch to more of a psychoeducational approach, to more family-centered, because we can't be there, but we still have immediate needs. And how do we triage those immediate needs, and how do we best meet them? And still having successes. I mean, a decrease in pain like that is phenomenal. The ability for someone just to share, like, do you see this? Do you see me? That is huge. From let me transition from here to here so that you're not taking that home with you, to I can't even imagine, you know, the amount of energy that and support that you're giving, and how you're even fulfilling yourself or taking care of self right now, because I don't think someone's playing music for you as you transition. And that self-care component when you're caring for others, and like we tend to do as therapists. But what would you say, if there is even one thing, is the biggest challenge that we have and you have had to face through this? If there's one big thing, and maybe there's not, maybe it's all of that.
I think the most challenging for me is bearing witness to the strains of visitor policies, and you know, providing support is amazing. Whatever we're able to do is wonderful, and it's a privilege and an honor. But families provide something that we can't, and that has been the most challenging. Is even the dynamic of, how come, you know, you're allowed to be in my, how come I'm on a call with you instead of my family, or how come I'm allowed, you're allowed to be in this room right now, but, you know, my dad isn't. That has been the most challenging.
I don't know if I view this as a challenge or, but it was in the beginning of just the strategy around the resources and how to deliver a service and still provide change. And I think that was a challenge of wrapping our head around just what do we need to do to make this the best. And the amount of hours, the non-billable hours that went into developing what we currently have was, you know, I think now in hindsight, it's it was a rewarding experience that I'm, you know, blessed and privileged to have the position that I have, and still be able to treat patients and provide music therapy. So I think overall there have been challenges along the way, but it's been a really rewarding process, and reflecting on that of just who we've been able to see to this point. And we do get a lot of those comments of, thank goodness you guys are still here. And so I think that, you know, those are those little moments that you're like, you have to hold on to them, you know, because you don't hear it all the time. And so that was, you know, that was a blessing. So.
Well, I'll jump in and share. I think what the biggest challenge I think that we faced as a team, but I think that we have faced as a profession as well, is just accepting this change overall, and also with that mindset, thinking about the fact that you know, this is a marathon, not a race, and that these changes are going to continue to come. And I think what we can do as leaders, and when I say leaders, I think not only individuals who are managing teams or programs, I think all music therapists are leaders of music therapy. I think what we can do is, in that leadership role, is understand the perspective that this is going to change. There will be ups and downs, there will be re-entries, there may be second waves, there may be third waves. What do we do to think strategically through that and to help guide others to do that too, and just show that we're relevant during all of this?
I agree with Seneca. That's probably the hardest for me and for our team, is to have to deal with all of the constant changing. And aside from all of that is external stuff, and then the internal stuff of how do we deal with, are we essential? Are we non-essential? Should we be essential? You know, how are we keeping ourselves safe, our patients safe? And so just being supportive of each other, but also creating the space to let these feelings out within our team, and really working together to see how can we shift things around. And just like Seneca said, this is a marathon. The end is not in sight yet, and it's very hard to process that. So I think for me, that's probably one of the biggest things for sure.
And I see, and I know you all have been phenomenal in keeping an eye on the chat, and there's a lot of questions, and there's a hunger, and I think a lot of it is, you know, looking for a handbook that says, you know, this is what you do in this situation, this is how you handle this, or this is what you can experience and expect, right? And one of the challenges in music therapy of the triangle of therapeutic relationship, the therapist, the music, the client, and how that intervenes, and how this has shifted and changed. But I'm not sure there's one answer, and it's so unique and personal, you know, whether it's a NICU to older adult at end of life, and whether it's physical or emotional or spiritual needs, that I'm not sure that we can even get to a lot of those questions, other than it sounds like we are being flexible and improvisers with intent to do the best that we can. But I don't know if you want to add to that. You can see a lot of those questions, and you know, how the relationship is, you know, by all means, it seems like you guys are able to still engage in those relationships. It's just using every resource you have to get there.
So I think from a leader perspective, immediately we could tell that someone was talking about the quality of the music. A lot of that has to rely on the equipment and the bandwidth of the internet that you're working with. So even advocating to buy all USB mics for all of our team so that the sound quality is good. And we had to determine that right away. So simple things like that could just make the quality better. Figuring out about the turn on original sound function on your Zoom, that kind of stuff. I mean, it really makes a big difference.
I also wanted to chime in really quickly to say, and this may be me just naming the obvious, but I think it's really helpful to practice receiving a virtual session.
Yes.
So we did some practice with our team with my little 14-month-old son, and everybody you know, did music therapy on us. And a lot of insights came out of that that were really, really helpful in both the introductions and the how to apply the music. So definitely have a colleague practice on you, and vice versa, as much as you can. It really helps.
Thanks for mentioning that, Jenna. We did that too, like paired up with one another in practice what we were going to do. That's huge.
Yeah, and I just want to add this. Someone asked, how will this change music therapy or viewed, and how it's viewed in the future? And I actually think that this will help shape how music therapy, I think one of the biggest, our biggest threats is that there's not enough of us providing this type of service. And so if you have developed, telehealth sessions and you are available and still can maintain that therapeutic presence and that relationship that is so important, and provide a service and not necessarily have to be in the same, even state if you can, I think we're going to see how this opens the door to a lot of people being able to access our services more and more. And even, from facility to facility, but from home to home as well. Individuals and groups, it might look a little different of your sessions and how you implement them and the audio that you have to adjust to. But ultimately, once you figure that out, you've opened the door to new opportunities for individuals and groups.
And it'd be interesting to see how this impacts global music therapy and how it connects us all on a much larger scale.
And Jenna, that made me think, Rich, I don't know if you're comfortable sharing some of the work that you're doing in your home country from Orlando.
Yeah, so just creating music, really, partnering with my contacts in the Philippines, creating like tribute songs and music just available, because there's not much music therapy. There's music therapy now there, but very, very small. So even just making that available there, because they have me as a connection. So all the online stuff, I mean, I've befriended iMovie even more than I ever in my career. So that's been really, really helpful. I wanted to talk to the person asking about the quality of music and reliance on therapeutic relationship and just the reliance on the music. I like what Joy said about there's not one size fits all. I know for me, I lean more music centered more than anything, but for the barrier of not being able to do that with their patients, it's got to be really, really frustrating for a lot of us. So I focus that energy somewhere else. So if I'm creating online video content for staff, I put all of my energies in how can I really rely on the music for that to affect the viewer, the participant in this type of exercise. So one of the biggest things that I've been telling my team is knowing what we can control and those that we can't, give it up and let that go, because we can't be carrying that baggage all over with us.
I actually support that as well, Rich, coming as a person who also has I'm sure all of us have fairly strong music-centered approaches, but I'm actually sharing a link in that chat right now that really showed how can you use that, and we actually connected our team too in doing that. I shared a link to a YouTube video of a staff appreciation song that we wrote for our medical center, and also used photos of staff members, but then actually wrote the song and edited it with our entire team from across different medical centers. So it supported us internally, but then also kind of had that external focus.
By the way, for those who are interested, I tried to share a picture of what our setup looked like, but I don't think it's going through. So if you're interested, you could just email me and I can share some materials with you.
We have like 2 minutes left, but I do want to tell I can't speak, our audience is that even if we didn't get to your question, I will be looking at these over the weekend. Fritz will give me access and we'll try to do that. But I also want to let you know that, and I hope you all don't mind me sharing this, is that you can go on social media and you can, Seneca has posted things, Rich has posted things, Jenna has posted things, Caitlin has posted things, and please, look up their sites. They're in their bios for the event link. There is information, but I also ask that you be mindful of their time, because really they are putting in above and beyond to meet the needs of their facilities right now, and they are to be commended for that. And even taking, the last hour and a half out of their time to be with us, we're so grateful for it, to give us insight into what is happening, and as well as how they're doing their best to navigate without a handbook, right? And so we do have to end. We will try to get to those. And again, Seneca also put information on the COVID task force through AMTA. And it takes a village. It absolutely takes a village. And so please join me if you know how to do the virtual applause on your Zoom, but thank our panelists, Jenna, Caitlin, Seneca, and Rich for joining us today, and Fritz for helping us put this together.
Yes, Joy, thank you so much. This has been incredibly informative. And a thank you, big thank you again to our panelists. If you have additional questions for our panelists or questions around topics addressed today, you can actually reach Joy via email.
Please email musictherapy@berkeley.edu. We will put together a document that way. And we'd be happy. Just give us, we're at the end of our semester and we're trying to get our students through as well, but musictherapy@berkeley.edu is the best way to put those questions, and we will work on putting together a document, and particularly those things to look for from, even before you start, you have to have the equipment and the sound equipment, and then we go from there, right? And how to do that. But yeah, music therapy at Berkeley.edu, please.
musictherapy@berkeley.edu. We want to thank all of our attendees for joining us on today's program. We hope you enjoyed today's conversation. I know I surely did. A special thanks to our Alumni Affairs Q&A curators, Joseph Driesen and Patrick Pharma. Please keep an eye out for next week's webinar event invitation. Don't forget to follow us on Facebook and on Instagram with our handle @BerkeleyAlumni. We look forward to you tuning in to our new content for our alumni webinar series. I know our next 3 webinars cover everything from project management to networking with authenticity, and my favorite, how to bolster your digital business in the new reality. I hope you will check some of these out. My name is Fritz Kuhnlens, and from all of us at Alumni Affairs and Music Therapy, we hope that you stay well and have a great day.
Be safe, everyone.
Bye.